Good morning, everyone. Thank you all for joining me here today for this presentation where we will delve into fetal development, monitoring, and where medical intervention could be possible. It's incredibly beneficial for all of you expectant parents and those of you planning to start your family to grasp a firm understanding on how your baby changes and develops from conception to birth. We will discuss methods such as ultrasound imaging, as well as the use of fundal height measurement and its benefits, as well as the screening processes for chromosomal abnormalities. We'll then consider some difficult circumstances where termination may be advised, alongside all process and treatment options involved. Towards the end of this presentation, I will talk about miscarriage, including risk factors and busting some common myths on the topic. Let's take a look at how a bundle of cells develops over the gestational period. The first trimester is categorized by weeks 1 to 12. The germinal stage is the first 2 weeks, which involves the successful fertilization of an ovum or egg by a sperm cell, which is then called a zygote. It then begins cell division by meiosis and begins to implant in the lining of the uterus. One part of the cell wall of the blastocyst is thicker, which then develops into an embryo, and the other part develops into the placenta. The embryonic stage is classified as weeks 2 to 8, and during which the blastocyst rapidly grows in the amniotic sac. Human-like characteristics begin to form, and major blood vessels develop early, pumping fluid by week 5. The neural tube, which then becomes the brain and spine, begins developing, and the head, arms, and legs are established. The fetal stage of development begins when your pregnancy enters the 9th week, where hair follicles, elbows, and toes form. Bones develop and begin to harden, and the sex of the fetus is established, although not detected by ultrasound scans. In the 10th week, teeth begin to develop, and the placenta is fully responsible for providing nutrients and removing waste products. By the 12th week, most organs are fully formed, yet continue to mature and develop. Gonads or sex organs are developing, and the fetus is now the size of your uterus, which then enlarges with its growth. The second trimester is weeks 13 to 26, and by the 13th week, the fetus's testes or ovaries are fully developed and the external genitals begin formation. By the 15th week, the sex of the fetus can be identified through ultrasound imaging, and fetal movement may be experienced. By the 28th week, ending the second trimester, the fetus is actively moving and responding to sounds such as your voice, and their senses are rapidly developing. From 28 weeks until birth is the third trimester. By the 30th week, the eyes can fully open, they may be grasping, kicking, or stretching, and red blood cells begin to develop in their bone marrow. From the 31st week, they begin to gain weight rapidly. Between weeks 32 to childbirth, they sense and can respond to light. They have a firm grasp, and fat is being stored across the body to provide insulation after they're born. Throughout the duration of pregnancy, it is crucial to monitor your baby's development. So let's take a look at some of the methods used. The term ultrasound may sound familiar to some of you, as it refers to the high-frequency sound waves that produce imaging from inside your body, allowing us and you to see the baby more clearly. Firstly, the abdominal or external ultrasound is advised at around 11 to 14 weeks, and then again at 18 to 21 weeks. This involves a small device that's used on your abdomen along with gel to allow smooth movement. The second type could also be performed, which is transvaginal or internal, which involves a similar process where the probe is inserted into the vagina, which can feel slightly uncomfortable, but it is completed quickly. This ultrasound provides clearer imaging due to closer proximity to the uterus, allowing us more accurate gestational age calculation, clearer imaging on the cervix and its health, and to identify any problems in early pregnancy, such as it being ectopic, which is when it develops outside of the uterus. The Doppler ultrasound is also using sound waves to produce images of your baby. It specifically assesses the blood flow through the umbilical cord as well as the placenta in the uterus. It is carried out as the same as the other ultrasounds with a probe and lubricating gel on the abdomen. It can help identify problems that could increase the risk of preeclampsia or impact normal fetal growth. Some reasons to have a Doppler ultrasound is those who have previously experience the loss of their baby, if carrying more than one, medical conditions such as high blood pressure or diabetes, or have noticed a reduction in your baby's movements. Fundal height measurement. Oh, we're going to have a few technical difficulties. Fundal height measurement is the measurable range between the top of your uterus to your pubic bone, which is taken with a measuring tape. At approximately 20 weeks of pregnancy, fundal height is normally equivalent to the gestational age. For example, at 25 weeks, the fundal height should be at 25 centimetres. The advantages of using this is that it's simple and non-invasive, with providing invaluable information, allowing to monitor fetal growth, position, and to measure the amount of amniotic fluid in your uterus. However, there are some limitations, such as it can be subjective, as measurements could be recorded differently by each healthcare professional, potentially causing inconsistencies with results. As well, factors such as obesity or maternal weight gain can affect this method's accuracy. Therefore, using fundal height measurement in conjunction with ultrasounds and various assessments provides a more detailed comprehension of how the fetus is developing, ensuring that you and your baby receive the necessary care and nothing is overlooked. Fetal monitoring during labour. First of all, it is significant to understand which part of monitoring plays which part during labour, being aware of necessary interventions or birthing plan changes that could be required. Intermittent auscultation is the standard method used for low-risk pregnancies, which involves either a stethoscope, which comes as plastic or metal, used by the midwife to listen to the baby's heartbeat against the abdomen, or the Doppler ultrasound as discussed earlier, which amplifies the heartbeat so both you and your midwife can listen. During the first stage of labour, your cervix reaches 4 centimetres of dilation. You're experiencing regular contractions. Your midwife will use either method to monitor their heartbeat every 15 minutes. When you're fully dilated in the second stage of labour, around 10 centimetres dilations, your midwife will monitor your baby's heartbeat after each contraction or every 5 minutes. The intermittent auscultation allows the mother to move freely, which can benefit the progression of labour. Continuous electronic fetal heart monitoring is the second method, mostly referred to as cardiotocography or CTG. This could be necessary in the cases of high-risk pregnancies, as discussed earlier, as well as reasons such as a breech position, which is where the bottom is heading out first, if anything irregular is revealed, or an induced or accelerated pregnancy or labour. CTG measures the pattern of your baby's heartbeats and the uterine contractions, which could be interpreted by your midwife to assess them. The reading could be taken by 2 small devices to be secured to the abdomen for continuous readings, or one device to the abdomen and a fetal scalp electrode inserted into the vagina, which is gently attached to the baby's head to provide accurate readings of their heartbeat. It isn't harmful and it is attached until birth. The CTG provides more accurate readings, allowing earlier intervention if signs of fetal distress or complications arise during labour. However, with this, mobility is limited, and these methods of monitoring can cause feelings of anxiety. Now let's explore the topic of birth plans. A birth plan is an excellent approach to communicate your preferences regarding delivery. It can open communication between you and your healthcare team, empowering you to make informed decisions. It isn't mandatory to produce one, but it can help you understand all possibilities. Discussing your plan and antenatal appointments helps you gain a better grasp of the process, avoiding potential disappointment and preventing unrealistic expectations. It's important to appreciate that while we always strive to fulfill your wishes, labour can sometimes be unpredictable, perhaps deviating away from the plan that's whilst it is essential to prioritise the health of you and your baby. It advocates for your wishes, enabling your healthcare team to provide support to provide a positive birthing experience, whilst allowing for flexibility to keep you and your baby safe. It can also include information on your preferences, such as involving oxytocin to stimulate milk production, to strengthen contractions or to induce labour. Forceps, which is a form of assisted delivery where curved tongs are used to guide the baby out, or perhaps an emergency cesarean birth, which is unplanned surgery to deliver your baby through the abdomen. In circumstances where complications arise, you would be informed of the process, why it is crucial to perform, and the possible risks, as well as your informed consent. It's likely decisions need to be made quickly, therefore being aware of possible interventions and changes to the birthing plan are very important, as it prepares you to make evidence-based decisions with your healthcare team to prioritise the safety and health of you and your baby. There could be some reasons for additional monitoring, such as if you've previously had a C-section, or if you're delivering more than one baby, or experiencing premature labour, as well as other risk factors such as type 2 or type 1 diabetes, preeclampsia, gestational diabetes, or if you experience any changes to your health during labour, including signs of fetal distress. Monitoring the developing fetus, advising interventions whilst advocating for your preferences all play an important role in prioritising your health and well-being, enabling you to make proactive steps. So between 10 and 14 weeks of pregnancy, you'll be offered a screening test to assess the probability of your baby having either Foetal's, Edwards's, or Down's syndrome. It is a combined test involving a blood test and an abdominal ultrasound scan of the back of the fetus's neck, taking a nuchal translucency measurement of the amount of fluid present. It is screened alongside the age of the mother and the medical history to calculate the chance of your baby having any of these syndromes. You can either choose to screen for none of them, all three, just Down syndrome, or Foetal's and Edwards' syndrome together. After 14 weeks of pregnancy, to test solely for Down syndrome, you'd be offered a quadruple blood screening test, yet this is less accurate than the first. To screen for Foetal's and Edwards' syndrome, you'd be offered a scan at 20 weeks. Screening isn't definitive, yet it provides data that can allow you to make informed decisions about your pregnancy. If you receive a lower chance result, you are offered further monitoring and further testing, but if you receive a higher chance result, you'll be offered an appointment to address the result and your questions and concerns. You can pursue further screening or tests. You can pursue a non-invasive prenatal blood test where fetal DNA in the pregnant person's blood is analysed, or you could pursue not to have any further screenings or tests, or request a diagnostic test. If you decide to carry out diagnostic testing, there are two forms, both providing an unequivocal result, with chorionic villus sampling, CVS, or amniocentesis. CVS is typically done from 11 to 14 weeks, but it is possible to complete it at a later date. Small sample of tissue is taken from the placenta in a minor procedure where a needle is inserted through the abdomen. Amniocentesis is typically performed after 15 weeks gestation, also involving a needle into the abdomen to take a small sample of fluid that surrounds the fetus. Both carry a low risk of miscarriage. Nevertheless, if you decide to utilise these options, your antenatal care will not be impacted, as your right to accept all offers of testing. It is reported that both procedures feel uncomfortable, yet be mindful it can vary person to person. As well as genetic testing, you will be offered screening for sickle cell disease and for fetal anemia. Sickle cell is an inherited blood disorder which is passed down from parents who carry the gene. Our blood consists of red blood cells, which are given their colour by a protein called hemoglobin, which is responsible for carrying oxygen around the body. When a person inherits sickle cell, their body produces abnormal hemoglobin, which can't move as easily around the body. Sickle cell disease can only develop when both parents are carriers of the gene, with a 1 in 4 chance of the baby being born with the disorder. Anyone can be a carrier of the gene, but those defined as high risk would have a family history of sickle cell or a family background from Africa, the Caribbean, South and Southeast Asia, or the Middle East. We offer optional screening with a quick blood test for high-risk mothers, preferably before 10 weeks, to give time for further tests for both parents. By testing early, we can provide you with all of your options, allowing you time to contemplate your next steps to make an informed decision. You'll also be offered a screening for fetal anemia, which is a condition where the developing fetus has a low red blood cell count, and it can be measured from mild to severe. Red blood cells contain hemoglobin, responsible for carrying the oxygen around the body. Inadequate hemoglobin levels can cause an increase to the fetal heart rate, fluids accumulate in the fetus, or heart failure. Screening is advised to identify fetal anemia, consequently receiving treatment to minimize the associated risks and outcomes. Some causes of fetal anemia include maternal infections such as parvovirus or syphilis, iron deficiency, as iron is the indispensable mineral that's involved in many processes in the body. Fetal anemia can be detected by blood tests that suggest parvovirus is present, ultrasound scans such as the Doppler ultrasound, which will measure the blood flow to the fetus's middle cerebral artery. Increased blood flow suggests anemia could be possible. Blood tests from the mother and umbilical cord could display isoimmunization, which is when the antibodies attack the fetal blood cells. Mild cases, this will be monitored with further blood tests to recognize if fetal anemia could develop. Fortunately, there are treatment options such as iron supplementation, which is taken orally and provided on prescription for mild anemia. The second step could be intravenous iron injections if the supplements proved unsuccessful. Severe cases, blood transfusions may be advised, where donor blood is injected directly into either the umbilical cord or into the baby's abdomen. Both are directed using an ultrasound scan. If the blood transfusion is offered, you will have a consultation to discuss the process, benefits, risks, and an opportunity to share your concerns and ask any questions. I'm now going to discuss the topic of medical and surgical termination. They might be a bit difficult or upsetting, but these feelings are okay, and I'll be able to answer any questions at the end of the presentation. Before termination is offered or advised, a consultation with a medical professional will be provided, where it would be explained, questions answered thoroughly, and also we would conduct a clinical assessment involving questions about your medical history to ensure the treatment options are suitable. Medical termination is viable before 10 weeks, involving the administration of 2 medications which could be taken at home or in clinic. The first is mifepristone, which blocks progesterone, resulting in the lining of the uterus beginning to break down, and therefore the pregnancy cannot continue. The second medication is called misoprostol, which is administered for the uterus to contract, causing cramping and bleeding, similar to a miscarriage. A surgical intervention would be medical management, which can involve it's given general or local anaesthetic, your choice, but it would be advised where appropriate. This can involve a suction device where the tissue is removed via suction from the uterus surgically, and that can also be done during miscarriage in the case of miscarriage. So miscarriage is categorized by the spontaneous loss of a pregnancy before the fetus reaches viability at 24 weeks. Yet they're more likely to occur in the first trimester, usually due to chromosomal issues. An important message to take away from this discussion is that miscarriage is common, it's just infrequently discussed in society. In the UK, it's estimated that 1 in 5 women will have a pregnancy that ends in miscarriage. There are some factors that can increase the possibility of a miscarriage, such as infection, hormonal imbalances, age, uterine abnormalities, smoking, the use of electronic cigarettes, recreational drug use, and alcohol, as well as perhaps thyroid disease or unmanaged diabetes. If you have any concerns involving any of these factors, please talk to your midwife or doctor. Help is available, and it's strongly advised to quit smoking, drinking alcohol, or recreational drug use. There are myths surrounding miscarriage. which are not scientifically supported, such as working unless you're exposed to radiation, exercise, stress or low mood, as well as having a shock or being frightened. And one damaging belief is that miscarriage is preventable if those who are pregnant just do everything perfectly. It's a dangerous myth that is impossible to achieve. We're all human and we do the best we can with the support of midwives, doctors and other healthcare professionals. We all have your comfort, health and happiness as our top priority. In the event of a miscarriage in the first trimester, expectant management allows the tissues to pass from the uterus naturally. It can take up to 2 weeks. When the miscarriage is complete, bleeding will cease and it is advised to take an at-home pregnancy test from the 3rd week to confirm. If you still have a positive pregnancy test, please seek medical attention as some tissue could still be remaining. Medical management is taken to pass the tissue for those who do not want to wait the 2 weeks or in the circumstance where it hasn't naturally begun or completed within 2 weeks. An incomplete miscarriage, misoprostol will be provided as a form of oral medication or vaginal pessaries, which aids the cervix to open to pass the tissue. In the case of a miscarriage not beginning, you'd be given mifepristone and followed by misoprostol 48 hours later. If you experience heavy bleeding, intense pain, abnormal discharge or a fever, you should seek medical care immediately. Surgical management may be necessary, involving the removal of tissue from the uterus with the suction device. As previously stated, you'll be offered the local or general anaesthetic, which would, again, be your choice, but where appropriate. If there's signs of infection, persistent heavy bleeding, or expectant and medical management were unsuccessful, surgical management would be recommended to complete the miscarriage. I understand that I have provided a lot of information today and you may be feeling overwhelmed, even panicked that you need to remember every detail. The fact is, you don't need to. At every stage, every decision, every concern, every complication, your maternity team is here to support you. We're not only here to overload you with information, we are here to provide guidance, advocate for your wishes, and empower you to make informed, evidence-based choices in the best interests of you, your baby, and your family. You aren't expected to know the ins and outs of all the processes, but being informed on screening for disorders as well as what to anticipate at each stage of pregnancy and labour is wholly beneficial. It gives clarity on all potential circumstances and empowers you to make necessary informed decisions to enhance your pregnancy and childbirth, bringing forth a positive experience whilst partaking in the most incredible journey of bringing a new life into the world. It can feel intimidating, perhaps frightening, but it is an exciting process, one where we are present to support you throughout this incredible experience. I hope you feel empowered by our discussion today. If you have any questions or would like to discuss any of the topics that I've covered in the presentation, you can find me around this area to further our conversation. Thank you for taking the time to attend this presentation today, and I wish you the best on your journey.